Surabaya. We are happy to announce you that up until now, the registrars have reached 850 people. We hope you enjoy tonight's webinar, and we will start this event with an opening remark from our beloved host, Dr. Herdiani Sulistyo Putri. Dr. Herdiani, the time is yours.
Thank you, Imran. Assalamualaikum warahmatullahi wabarakatuh. A very good day to you all and good evening from Surabaya, Indonesia. My name is Herdiani Sulistyo Putri and I will be your host in our webinar tonight. I am staff from Department of Anesthesiology. Department of Anesthesiology and Intensive Therapy, Faculty of Medicine, Universitas Airlangga. It is with great pleasure that I welcome you all to the 10th Airlangga webinar conference series with our topic today is cardiopulmonary resuscitation for COVID-19 patients. I especially would like to welcome our moderator, Professor Dr. Nancy Margarita Rehata, Doctor Anesthesiologist Consultant from Department of Anesthesiology and Intensive Therapy, Faculty of Medicine, Universitas Airlangga, Surabaya. Good evening, Prof. Good evening. Our two speakers tonight will present very interesting topics. Our first speaker is Dr. Pravin Chahar, MD, Anesthesiologist Consultant from Anesthesiology and Critical Care Medicine, Cleveland Clinic, Ohio. Good morning, Doctor.
Good morning. Thanks for having me.
Yes. And the second one is Professor Dr. Agus Purwadianto, Doctor, Forensics Consultant from Department of Forensic Medicine and Medical Legal, Faculty of Medicine, University of Indonesia, Jakarta. Good evening, Prof.
Selamat sore. Good evening, everybody.
Our distinguished panelists tonight are Dr. C.K. Chung, MD, Senior Consultant and Head of Division of Respiratory and Critical Care Medicine, Department of Medicine, National University Hospital, Singapore. Professor Dr. Edi Raharjo, Doctor, Anesthesiologist Consultant from Department of Anesthesiology and Intensive Therapy, Faculty of Medicine, Universitas Airlangga, Surabaya. Professor Dr. Aryono Junet Pusponegoro, Doctor, Digestive Surgeon Consultant from Department of General and Digestive Surgery, Faculty of Medicine, University of Indonesia, Jakarta. And all the guests of honors, good evening, Prof. and doctors. Tonight's agenda will be the first one, opening remarks from me as the host. And then the second one, presentation from our speakers and will be moderated by Professor Rita. The three, discussion and question and answer with our panelists. And for closing. Before we start, I will let all the attendees know about the rules of this meeting. Okay, so the rules for attendance, full participation during webinar is required. By the end of this webinar, complete a survey form and write your name and title for the certificate. Notifying your presence in the chat room is not advisable and disturbing for other participants. Leaving the webinar room or disconnecting before webinar ends, you may need to re-register or rejoin. Rules for ED accredited. Full participation during webinar is required. By the end of this webinar, complete a survey form and write your name and title for the certificate. The certificate will be sent to your registered email address. And rules for question and answer. Use the Q&A box on the middle of your Zoom panel and write down your questions. Do not ask in the chat box since it might drown other important statements. Question will be shorted and discussed after all lectures have been presented. Okay, to shorten the time, I would like to invite Prof. Rita as the moderator. Prof. Rita, the time is yours.
Thank you, Dr. Dian, and good evening, friends and colleagues. As Dr. Dian already mentioned everybody and every guest, so I think I will go directly to the presenter. The first one is Dr. Pravin. So, Dr. Pravin, it is your time. Please share your PowerPoint.
Thanks, Prof. Rehata. And let's start the presentation.
Yeah.
Are you guys able to see my screen?
Yes.
Are you
Yeah.
able to see my
Okay.
presentation?
Yeah.
All right. Good. Good morning, everyone. Thanks a lot for inviting me in this webinar. I would rather say it's good evening in Indonesia. And special thanks to Prof. Rehata, Dr. Chandra, and all the organizers of this event. So my name is Praveen Chahar. I'm a staff anesthesiologist and critical care medicine at Cleveland Clinic. I'm also the co-chair of Critical Response and Resuscitation Council and director of Acute Medical Emergency Team, where we made the guidelines for cardiac arrest and respiratory arrest, especially in COVID-19 patients. And just a brief background, I did my medical school in India, and then I was, before coming to US, I was at Royal Brompton Hospital in London, where, I mean, we were having the swine flu epidemic at that time, but we know that there's nothing, we haven't seen anything of sort of COVID-19. So without wasting more time, I'm going to start my presentation. So one of the, with the COVID-19, it is a completely new pandemic, and we haven't seen anything like that in our lifetime. So very little is known about this condition. I mean, of course, there are every day we are having new studies and new treatment modalities, but still like we are learning every day. And this webinar is a great continuation of that learning. So cardiac arrest, now we know that when patients with COVID-19, typically they have pneumonia, around 12 to 15% of them end up getting admitted to the ICU. And then we know that at the extreme end of the suffering is cardiac arrest. Now, as anesthesiologists and intensivists, we are all trained in cardiopulmonary resuscitation, and this is our area of expertise. But still, there are many specific points to cardiopulmonary resuscitation in COVID-19 patients, which we need to be aware. Now, we know that COVID-19, it is highly transmissible, and we know that since it started in Wuhan, it has spread to all the places in the world. And cardiopulmonary resuscitation is also a specific procedure because in which there is a lot of aerosol generation. If you are doing chest compression, there is aerosol generation. Intubation is the procedure which is associated with highest risk of getting COVID-19. And there's no wonder that anesthesiologist was one of the three specialties which were at highest risk of getting infected, and we had more anesthesiologists getting infected with COVID-19 among healthcare workers compared to other. And then, I mean, cardiopulmonary resuscitation, we know that it's not something that we can do with one or two people. It needs a full team. So it requires a lot of resources. And we have to be, I mean, at the epicenter of the pandemic, especially like in places like New York and then in Italy, like the health system got overwhelmed, and then like they had to make a decision where to direct the resources. So I mean, many times they did not even have sufficient people to do cardiopulmonary resuscitation because they were completely overwhelmed. So that's again something that we have to keep in the mind. And then the prognosis from COVID-19, though there are very few studies which are done looking specifically at prognosis of cardiopulmonary resuscitation due to COVID-19. But we know that when patients with COVID-19, when they are having cardiac arrest, typically like they are in ICU, they are on many pressors, and more than likely they have comorbidities. So these are the things that we need to keep into mind before directing all the resources. Of course, like every situation is entirely different. So I'll start with this study about from Wuhan, China, where they looked at what is the rate of return of spontaneous circulation after cardiac arrest of cardiopulmonary resuscitation in COVID-19 patients. And they looked at around 136 patients who had cardiac arrest. And then they found that the rate of return of spontaneous circulation was only 13%. And then only only 2.9% of patients were discharged from the hospital. And they had like 136 patients, and they found that only one patient out of 136 was neurologically intact. Now, if we compare with another study from Beijing, because it's not fair to compare different health systems. So this is again another study from Beijing, which looked at rate of return of spontaneous circulation in non-COVID patients. And they found that they were able to achieve a return of spontaneous circulation in as many as 39% of patients. And then almost like 13% of patients, they were able to send them out of the hospital. So we can see that it's almost like the prognosis of cardiac arrest in COVID-19 patients is not great. And it's almost like 20 to 30% of the prognosis of in-hospital cardiac arrest in non-COVID-19 patients. Then one of the most important things about management of cardiac arrest is preparation. And as anesthesiologists, I mean, that's our domain. We always like to be highly prepared, because we know that many things can go wrong. But it's really important in case of COVID-19, because there are many different, the pathophysiology of cardiac arrest in COVID-19 is different from the most common causes of cardiac arrest we see otherwise. Now, in preparation, one of the most important things is advanced directives. And so at our institute, we are very aggressive in that approach. And like if the patient is having multiple comorbidities, and if they already have a living will, we always take that into consideration. And also, the moment patient with COVID-19 are admitted to the hospital, we always have a discussion with them and the family members as of how much resuscitation they want. And again, like it's a dynamic process once they're in the hospital, and then if they're getting more sick, then we have if there is a significant change in their clinical condition, we'll again have that discussion with the family members and with the patient. Our main aim is to, we are very careful about to make sure that whatever we are doing is according to the wishes and beliefs of the patient. Then timely intubation is another thing which in studies in Wuhan showed that with timely intubation, we mean that these patients typically they have very poor respiratory reserve, and they tend to desaturate very rapidly with any increase in oxygen demands. So the timely intubation is the key, because many times if we are intubating for the first time when the patient has got cardiac arrest, again, like we are exposing many healthcare providers to multiple aerosol generating procedures. So we recommend timely intubation, where it should be done like more in a, that doesn't mean premature intubation, but it means that if the patient is very tachypneic and is still having high oxygen requirements, that's the time to intubate the patient. Then ideally patients with COVID-19, especially in ICUs, should be in negative pressure rooms. And we know that our aim is to prevent spread of infection. However, it may not always be feasible, because not even the best health systems in the country, they have all the negative pressure rooms. So, but if we can have, and if you have the luxury of having it, COVID-19 patient should be going there preferentially. Now, in COVID-19 pandemic, there is an increased use of mechanical compression devices, because we want to limit the number of people in the room who are helping in resuscitation. And with mechanical compression device, I mean auto pulse, we were able to give chest compressions, and then we can direct our resources to do other things. Then we recommend, now in COVID-19, as anesthesiologist and intensivist, whenever a patient has got cardiac arrest, it's our tendency to just go and rush into the room. And we typically, as healthcare professionals, we don't regard patient safety, we regard patient safety as prior to our safety. But that may not be the best thing in COVID-19, because we are valuable resource. And as we have seen from examples in New York and Italy, that we are required, if the healthcare force gets infected, then there's no one left to take care of the patients. So it's very important for us to take care of ourselves. So what we do is that we have a personal protective equipment bag, which is just outside each room of COVID-19 patients. And so that if there's a code, then code or cardiopulmonary arrest, then we can just go to get the personal protective equipment and we can go in the room. Now, as anesthesiologists and intensivists, we are training cardiopulmonary resuscitation, and we have a lot of mock cardiopulmonary resuscitations. But it's also very important to have some codes specific to COVID-19 patients. That way, like, we are well prepared, and when the actual code happens in COVID-19, we can ensure that we don't compromise our safety. Now, with the if the patient with COVID-19 undergoes cardiac arrest, then this is the time that we have to make sure that we are well prepared before we go into the room. And by well prepared, we recommend having a full personal protective equipment according to CDC guidelines. And then we recommend a buddy system where there's a buddy of yours is watching yourself to make sure that you're following the proper sequence. Now, even if it's a very difficult situation and most of us will be inclined to just rush into the room, but then, as I said, that it may not be the best thing, because we need to think about the patients which we can care if we don't get sick. And healthcare providers are disproportionately represented among the infections of COVID-19 patients. So even if it's delaying care, it's okay. I mean, we have to make sure that we are well prepared. We have personal protective equipment before we enter the room. Now, this is not the time to have multiple people in the room, and only people who have assigned roles, they should be coming into the room. And we can have a runner. By runner, I mean extra people who are donned in personal protective equipment. They are just outside the room so that they can help us with supplies, or if we need an intubation equipment or any other help, they can go and get it for us. Now, when we have only one rescuer, we recommend starting compression only CPR. But as we know that when we do chest compressions, that also leads to aerosol generation. So we recommend use of a barrier device. I mean, we recommend we can put a mask, surgical mask on the patient and give them oxygen while non-rebreather mask. Or if we don't have any mask, we can just use, if there is a towel or something like that which is present, we can cover the face of the patient while we have extra help to take care of the airway. Now again, this is a situation where we are going to use mechanical compression device early, and we'll try to have connect the patients to autopulse or one of the other compression device as soon as possible, so that we can direct our attention to area management and other things, and also we can minimize the number of people in the room. Now, typically, especially like it's an unlikely scenario in patients with COVID-19, because typically these patients are on a lot of presses and already they are well lined up. But I mean, if it happens, if the patients don't have any intravenous access, like similar to non-COVID situation, we recommend early intraosseous access placements. And then the ACLS protocol is similar. We use the standard medication in standard doses, and we have the standard protocol. And I mean, that's not the aim of this discussion, but like, for example, the ventricular wayfair VT early shock, so the protocol does not change. Our main focus is to prevent the spread of infection and getting infected. And then if you are using mechanical compression devices, it's very important to use them in continuous mode so that there is continuous chest compression while we are getting ready for intubation. Now, airway management is one of the forefront of management of cardiopulmonary resuscitation in COVID-19 patients, because most common cause of cardiac arrest in this patient is respiratory, because they start with pneumonia and then typically it spreads to multi-organ failure, cytokine storm and everything. Now we should have HEPA filters in the room of COVID-19 patients. In this situation, we don't recommend bag mask ventilation or rescue breaths, because I mean, again, it is a very high aerosol generating procedure. And we don't recommend using bag mask ventilation, and we recommend early endotracheal intubation. and the patient is on auto pulse and patient is on continuous mode of chest compressions, we recommend pausing it. Or if you don't have auto pulse, that's the time that we can pause it so that airway is secured with a cuffed endotracheal tube. Now, this is not the time to learn about intubation, so we recommend using video laryngoscope, and the most experienced provider should be doing the intubation. If we can't, if we don't have intubation things ready in the room, or if we don't have the experienced provider who can do intubation, we can always ventilate the patients with a supraglottic device, that's laryngeal mask airway. But we should make sure that there is a HEPA filter attached to the LMA. And then there are a variety of barrier devices which are available to prevent aerosol generation during intubation. We can use one of those if it's available. Fiber optic intubation is not recommended in this situation because again, it has got very high aerosolization. Again, every situation is entirely different, but this is the time that we should focus on using video laryngoscope and to secure the airway. And video fiber optic intubation is not something which will be our first choice. Now, how to confirm endotracheal tube position? Auscultation is no longer recommended, especially in COVID-19 patients, because A, it's not reliable, and B, again, like if you are giving bag mask ventilation, you are generating aerosols. So we recommend confirmation with inline capnograph, or if we have ultrasound, point of care ultrasound, we can quickly look at the lung sliding, and those will be will confirm endotracheal tube position by those methods rather than auscultation. Now, HEPA filter position is very important. We should have HEPA filters on the expiratory limb, and then it's always important, like similar to donning the personal protective equipments, it's always better to have 2 personal verification to make sure that when we are transferring the patients to different locations, or if the patient is not in ICU, we don't end up contaminating the whole hospital. And this is one situation, it's very important to avoid circuit disconnections. Now, ideally, there should be a ventilator in the room. And once we intubate the patient should be connected to the ventilator with inline capnograph so that there are no circuit disconnection. And once the tube is in, the patient just gets ventilated and there is no spread of infection. Now, quickly, I will talk about few special considerations in COVID-19 patients. I will start with extracorporeal membrane oxygenation. Now, we know that in cardiac arrest in known COVID-19 situations, typically like this is one of the things that we like to go for. In COVID-19 patients, there is insufficient evidence to support its use. I mean, ECMO is useful in preventing cardiac arrest, like the patient have got very high oxygen demands and very poor oxygen supply, then definitely like it can be used just to salvage them to prevent cardiac arrest from happening. But that's not something which is recommended in patients who are arresting with COVID-19, because we know that unfortunately prognosis is also not that great, and ECMO we have limited resources, so that's not something that we recommend. Now, I will talk about prone position cardiopulmonary resuscitation. Now, the American Heart Association in their updated guidelines, they did mention about prone position CPR, especially in COVID-19 patients. And because prone positioning, we do use it in patients who have got very bad respiratory failure due to COVID-19. So, but if the patients are already intubated, we don't recommend turning the patient supine, because then it can lead to circuit disconnection and it can lead to they're on many lines. If the patients are not intubated, which some hospitals are doing, I mean, they are even having spontaneously breathing patients, they are proning them early to prevent the progression of to increase the oxygen delivery. In that situation, we can turn the patients and do cardiopulmonary resuscitation in standard situation. But if the patient is intubated, we avoid turning it. And then they have described the way of doing cardiopulmonary resuscitation, where you do chest compressions over T7 to T10 vertebral bodies. And they recommend that you can always put something in front of the chest so that there is we are able to give good compressions. But again, it's very controversial. There is very limited evidence of its use. Most of the studies were done in mannequins. So we don't practice at our institute, and that's not something which is practiced routinely. Now, again, these patients have got multiple comorbidities, and then we should be mindful of how long we want to do cardiopulmonary resuscitation, and that should be an ongoing discussion. And at any time, if the team feels that the further efforts are futile, that will be the time of considering to terminate the resuscitation. If the patient do receive return of return of spontaneous circulation, then the post-cardiopulmonary resuscitation care is standard, and it's similar to non-COVID-19 patients, which includes cooling and all those things. Now, again, it's very important to minimize cross-infection. If we are transferring these patients, we should be very careful about that. And then in the end, like if you're using disposable equipments like the video laryngoscopes, it's very important to take care of that, because when the health system is overwhelmed, they are required in many situations, many places at the same time. And then we can, doffing is also as important as donning. So once we are leaving the room, it's very important to doff according to CDC guidelines with a buddy system to make sure that we are following proper sequence. Because when we are taking out personal protective equipment, that is the time that if it's not done properly, it can lead to spread of infection. So with that, I will take any questions or comments.
Thank you, Dr. Pravin. I think the question is after the panelists. So we proceed to the next speaker, and that is Professor Agus Purwadianto. Prof. Agus, please. It is okay with your PowerPoint?
Thank you very much, Professor.
Okay. Okay. It's clear.
So, it's a very thanks for the committee that allow me to make such kind of presentation about the ethical implementation on CPR. I would like to share screen first. Hopefully that will be work. Is it already?
Yes. Maybe it is the sound is you have to make it a little bit down, the sound.
Yeah.
Because it's echoing.
Thank you. The slide already shown?
Yes, the slide is already shown.
Okay. Thank you. Talking about the ethical aspect, I heard of the Googling of the literature, and then I found that the only suitable for discussing tonight is from Kramer et al. And hopefully that it will be enough for us to understand. Yeah, since these articles also being appraised by one of the other writer, and then we know that in this context, yeah, slide maybe. In this context that we discuss synopsis in this first slide, please. Okay, sorry. Sorry. Yeah. we know that the role of CPR is very important here, and we have such kind of dilemma because you know that the ICU should be one of the consideration for making CPR. So, to my knowledge, that the availability of the ICU beds and the ventilators is one of the parameters that we should consider about the efficacy of the CPR. So in that situation, that in hospital situation is a little bit different with the out hospital, and we know that in this context that the healthcare professional should have a timely prepare, while the CPR should be done with donning the PPE as an equipment. It is like a standard because the CPR cannot be done if the healthcare professional doesn't wear the PPE. So this situation makes the ethical principle here is autonomy, transparency, and also harm reduction. And in this slide, can you show the slide? Everybody can see the slide?
Yes, it is okay, Dr. Profagus. We can see it.
Okay. So the other point is that in this situation, we should consider the medical condition and age of the patient. And the third consideration is we should protect our healthcare professional with the equipment. So this is like we should consider our balancing between the benefit for the patient and also the protection of our healthcare professional. Yeah. The other one is I'm also searching the systematic review is from what we call the paramedics point of view, that here is from Indonesian nurses, and then they said that the CPR should be considered with the patient's situation, like correcting the position and something like that, because as first speaker already said that aerosol is being one of the mode of transmission, so not only the droplet, yeah. Okay, and the other one is also similar, that we should minimize the risk of contracting of the COVID to our healthcare professional doing the CPR. Yeah, the ethical aspect. Yeah, I should give you the picture that this is a micro ethics, because one doctor to one healthcare professional to one patient, but it should be related with the impact base. It is in line with the beneficence principle, and also the continuity of the ICU's availability. So if, for example, in the red area zone, this is the assumption that we should also deal with the source of the capacity of the hospital, and then also the other next patient. I mean, in the hospital context, we should consider it mesoethics. So the basic setting assumption is leading to like a high precautionary principle. Yeah, to my knowledge, that the healthcare professional, especially medical doctor, especially the anesthesiologist, is a very scarce resources should be maintained in the hospital. So in this context, all of the ethical theory is based on consequentialist theory in compare with the deontology and virtue theory. Consequentialist is in line with the EBM principle, but deontology is like the obligation of the medical doctor from the intrinsic value of the person. And the aim of
Bagus. Please, you have to say next if you will move to the next slide, because the slide is running from here. Just say next.
okay.
Otherwise, it is still the only one slide there.
Okay.
Please say next. Okay.
Okay. So the ethical aspects already. Next slide. Next slides, please. Yeah, in the aim of CPR implementation here, yeah, we should consider that the CPR in the COVID patient should be also based on the crisis standard. You know that the crisis standard is more general in situation, but the goals or the aim is save the most lives possible and under severe resources constraint. So it is in line with the beneficent principle and also the justice principle. Yeah, next slide. Yeah, and according to the general principle in the crisis situation, this is a principles here from the fairness, the duty to care until the accountability. But according to Kramer, that this principle, it is a few implication for the CPR in COVID patients. So it means that the CPR patient, it is more difficult or more complicated in compared with the just crisis situation in general. Yeah. Slide, please. And the other one is that we should consider or should make CPR needed, yeah, for the patient. That all of the medical indications should be done, but in this context, that CPR is cannot be interpreted as standalone procedure for isolated individual patients. So many of the ethical consideration is always consider that it is a continuum, you know, between the CPR with the availability of the ICU. But in this situation, like in Western countries, it is connected with the advanced directive document. I mean, in Indonesian context, it's waris. So it is a little bit rare with Indonesian culture. And we know that advanced directive considering or symbolizing the autonomy. And in this situation, the autonomy cannot outweigh the beneficence and justice. So in this crisis situation, beneficence and justice is the prima facie principle. And yeah, we also understand that in the context of medical indication, it is you know, that is very good efficacy if we talk about the cardiac catheterization labs, where the arrhythmic arrest is in the patient's condition. And the other medical condition, CPR is not as good as arrhythmic arrest. Next slide. For the healthcare professional, yeah, should done the PPA timely when doing CPR. So this is like you know, such kind of preparation that in the CPR, and the patient should be being selected with the medical indication. I mean that the clinician should consider about the golden period of CPR, yeah, because you know that donning the PPE is also take a few minutes. So it is a little bit of delaying of the efficacy of the CPR. And in this ethical consideration also that the doctor or healthcare professional safety is part of public safety. It is more prima facie outweigh the patient safety in this context. Because as maybe the first speaker mentioned that COVID is categorized as a class A infectious diseases, so it's highly transmissibility and so very dangerous. Next slide. And during the facing the patient need of CPR, the hospital should implement the transparency principle. So in this context that the hospital should follow the regulation beyond, yeah, especially in Indonesia, especially with the national and local district emergency and also public health emergency, yeah. And we know that in the context of mesoetic or hospital duty here, that hospital should open duty 24 hours during a day, yeah, and then it should be cannot be delayed. So that's why that we should consider whether the CPR will be influenced by the insufficient of healthcare professional or physical collapse. It is one of the situations that we consider the future patient and also the running of hospital duty for other medical indication except the cardiac arrest and something like that. So according to the medical staff bylaws, and CPR is categorized as resource intensive and also a little bit complicated and difficult procedure decision. So it will be come to the situation that this is called ethical dilemma. Yeah, and some of the situation will give that a medical doctor should consider the CPR in the COVID is like treating the futile treatment, yeah, because the efficacy is only 25%, yeah. And the other principle is harm reduction, and in this context, that according to the procedure is aerosol transmission, yeah, like the first speaker already said, and also in the wider context is about the disparities and also about the inequalities and also the the sparkling the conflict between patient and the family, yeah. Yeah, talking about the CPR in the COVID patient, it will come to the ethical dilemma. Here, many of situations like in the clinician is dealing with the term like continuous balancing, and also result of society, access to healthcare resource allocation, and also and the important one is gap between professional obligation and possibilities. So every clinician should make what we call prognosis, yeah, like as the speaker already said, and also dealing with the impact of the CPR, whether it will be a benefit for the patient or reducing harm for healthcare professional. And we have a PNPK, I mean the professional guidelines that hopefully that will be established by the professional association in this context. And according to the ethical dilemma, here, many of the ethical decision process, the medical doctor will consider about the antinomy situation between the truth and the loyalty here. So the individual versus the community, yeah, also short term versus long term, and also justice versus mercy. So in this CPR patient, COVID patient, all of the consideration here should be elaborated and step by step. It should be come into the one conclusion decision. So it needs not only one medical doctor, it needs the health ethics committee to also giving the advice for the clinician. Yeah, but we know that the advice it's questionable because it should be decided in a few minutes or a few seconds maybe. Yeah, so this is the dilemma. Yeah. And according to the situation, because this is not only microethics, it is a national one. So that's why that this ethical dilemma, yeah, whether we should forgo or not forgo the CPR in the COVID patient, it should be in the national level situation. So I mean, it should be regulated or guidelined by the professional association. Yeah, and this is the importance of the hospital ethics committee. Yeah, as you know that in Indonesian regulation, while the physician is being confused about what to decide, forgo or not forgo for making a CPR in COVID patient, they should get advice from the hospital ethics committee. So this is the situation that clinician should have like a second opinion or giving the supportive decision from the ethical committee. Yeah, and yeah, according to the process of making an ethical decision, yeah. In this theory, that ethical decision is a balancer of medical decision. So, but ethical decision usually one step behind for after we know everything about the medical situation or medical decision. And in the situation that COVID patient, it is also can be viewed from the microethics, from the macroethics, and also the mesoethics, and also the macroethics. And in this situation, usually medical doctor has to use their best evidence. Yeah, this is an objectivity, but on the other side can also facing the patient's subjectivity. I mean that, for example, that this is a public figure and then have to cardiac arrest while the public figure suffering on COVID, and this is like a dilemma. Yeah, and the other one is we should treat the complex cases by make a step-by-step judgment and also conduct, and also we should consider the patient's condition, also the patient's context, and also the patient's best interest. Yeah. And the other one is for considering the ethical decision is we should understand about the underlying factors of dilemma here. One is from the medical ethics education, and the other one is from the medical ethics. Yeah. And the medical ethics education, yeah, like that all of the bioethical principle will be influencing the decision. So it is called cognitive based. Yeah, but the other method is behavioral based. We should also have maybe the good roles of the seniors or medical doctor who will give the guidelines or supervision about which step should be done. And the other one is that considering about the colleagues, yeah, from the the hospital ethics committee and something like that. And for making a consideration in Indonesia, we should consider the doctor's qualities and character. It is in the preamble of the medical ethics code. It is depend on the good intention, sincerity, work completeness, and social integrity of the medical doctor. And the other one is based on ethical theory and also using the basic moral principle as middle range principle, like Osham and Childress know about the autonomy, beneficence, normalizations, and justice. Yeah, and also we should also fit in or confirm with our case context in the medical codes of ethics. Yeah, the last slide is last slide. Next slide. That the general consideration, yeah, we should come from a decision-making processes. We should based on rationality, this normative ethic, and we talk about the moral justification. And the other wing is descriptive ethics, and we should consider the emotive structure, and we talk about the balancing. So this is the like a pathway, for making a decision-making process, and the justification method is should be based on the rational person, yeah, or rational person, and we can come to the like Islamic law is under the five consideration here. It's a prohibition, discourages, and allows, mubah, yeah, and encourages, yeah, and requires, and sunnah, and also wajib, yeah, requires. Next slide. Yeah. Conclusion is, yeah, I should, before come to the conclusion, I just thinking that all of the complicated problem about CPR in COVID patient will be clear if we can create the robot, the robot for making a CPR, yeah, with the accuracy and with the method, the safety and something like that. So the robot will be replace our situation, yeah, our situation, our problem. So the CPR implementation is a single procedure to save life of several acute medical condition, yeah, have inherent high risk contracting COVID to helping healthcare professional. And the ethical aspect of CPR mostly based on consequentialist theory. It is in line with the EBM, yeah, then deontology or virtue theory of ethics. And the decision-making process is, belong to normative ethics, yeah, on rational being, giving potential dilemma, yeah. And the last conclusion is to achieve the, the more clear situation or consensus that professional association should achieve responsively all of the medical background or medical development of COVID, while also considering the humanities as one of the most consideration. Hopefully, this is my presentation, and terima kasih. Thank you very much.
Thank you, Prof. Agus, for your comprehensive lecture. And it is the keyword is dilemma. And it is maybe became a futile treatment. So let the panelists give the comment, and also the invited panelists. I think there's 11 here, and also the participant, if there's still time for it. So we start with Professor Aryo. Please,
Okay.
you can just give slides, 1, 2 slides, or just speak it out.
No, I don't have any slide, Prof. So I just talk.
Okay? Yeah.
After listening to Dr. Profit and Prof. Agus, I think there's two dilemmas. You do CPR or you don't CPR. If you don't do it, are you can be sued or not, or ethically? Because all doctors, we in the whole world, we have the Hippocratic oath. On the other side is the ethical things. So this is conflicting. And I think that for a patient, the cardiac can be out of hospital, where the layman normally takes, can help. But now only maybe chest compression only. And then the pre-hospital phase. In developed countries, the ambulance will arrive in 4 to 6 minutes. It can help. But here in developing country like Indonesia, we don't think the ambulance can arrive. So what to do? So what we did in our ambulance service foundation is to do two trias. First, when we get the telephone call for help, and by doing the triage, then we divide the patient into 10. Is this the ordinary patient, cardiac, stroke, accidents, and so on? Or is this a COVID patient? By asking, do you have fever? Do you have cough? How long have you been having it? And then, did you visit the hot zone? Then we decide which type of ambulance to go. Because we have two types of ambulance, the emergency ambulance, and then the ambulance specially designed for infectious diseases, which I myself designed it, because my hobby is, beside emergencies, is also automotive. So I decided, then we can decide which ambulance to go. And then when we arrive where the patient is, we do another triage. We look at the patient, is he in bad condition? How is his respiration rate? So by this, we know, okay, if the respiration rate is very fast, maybe something is wrong. Maybe it's a COVID patient or not. Then we measure the temperature from the air, so we don't have to touch the patient. And then maybe there's, we can use the pulse oximetry. The pulse oximetry shows the heart rate and also the saturation of the patient. The saturation is good, around 80, okay. If the patient belongs to the day-to-day group, we do it like we do it every day, routinely. But if this is in a patient with a fever, which we are suspicious of COVID patient, then there's another problem, because if the saturation is around 80, if below, then it's hopeless. Maybe you don't have to do anything. But it's above 80, then maybe according to the autopsies in China, in Italy, there's a lot of mucus in the respiratory tract. So I advise my residents to put the patient not on a prone position, but lying on his right side, hoping that the trachea is like this, you write on the right side, hoping that the left respiratory tract is going to be free. So we give the patient only high volume of oxygen, no bagging, because that will infect my paramedics, and hoping that the patient can survive with one lung ventilation until he reaches the hospital. And then you are in the emergency department, then you got also to do the triage again. Whether this is normal emergencies or day-to-day emergencies, or is this a COVID patient? And the problem here in Indonesia, almost all hospitals accept COVID patients. So all the major hospitals are like a hot zone. That's the problem. And Indonesia is a large country. It's not only Jakarta. Maybe Jakarta is not so bad, but not well organized. Maybe not well trained also. But outside Jakarta or Surabaya, outside Surabaya, you got already big problem. Especially to the small islands where there's only one doctor or one surgeon or whatever, or all the way to East Nusa Tenggara or to Papua, you got another problem. Like Papua, it's you are in the outback, you are the only doctor. It's really a dilemma for him to do CPR or not to do CPR. This is the main problem, I think. And like Dr. Pravin said, if in hospital, then you can plan your patient. Okay, this patient, and the aim is to do early management or early intubation, whatever. But do it early, not too late. So I think we, the professionals like surgeon, OBGYN surgeon, anesthesiologist, and internal medicine, we should sit together and talk what to do. What are the rules? Because I was thinking about the general doctors, physicians. Our residents who are scared to do, they are scared to make a mistake, and they are scared to be infected, and they are scared that his patient will die. So I think we got to come to a consensus within us. Which patient to do CPR and which patient not to do CPR. For example, COVID patient, okay. Old age like myself, if I got CPR, COVID, I think you don't have to do CPR on me. I'm too old already. And if the patient got a comorbid, and so on, then you can decide this and make it as a rule for the country and agreed by all professionals, organizations, so that the general physicians in the emergency department and our residents especially, they are so scared. Do I do wrong? Or because they are also afraid that, okay, they are working. And also for the nurses and the pre-hospital, okay, in Jakarta, we have the doctor's control, but outside Jakarta, there's no system at all. Even Jakarta system is bad, not well organized, not well trained. That's the problem. So what I suggest is for us, professionals, or in the colleges, professional organizations, sit down and agree on the rules, what to do, which patient to do CPR, and which patient not to do CPR, and when to let the patient die in dignity. I think we cannot wait for the rules from the Minister of Health, it's us, professionals, we should decide. And also, if possible, we doctors who are involved in critical care medicine, we should try to analyze the patients with COVID. Why did they die? Maybe we can know something. And in China, US, Italy, they do autopsies. In Indonesia, our Eijkman Institute, they declared the virus in Indonesia is different than in Wuhan or in Italy because they did mutation, and there's 3 types of virus in Indonesia. And we don't know what it's doing. So we got to do an autopsy, I think. It's most important. So number 1 is to get together, sit together, agree on the rules, do an autopsy, and then we know what happens to the human body. And then we treat not symptomatically, but according to the need of the patient. I think maybe that's all I can talk because it's already like an obsession for myself. Thank you, Dr. Rita, Prof. Rita, thank you.
Thank you, Prof. Aryo. So I think the key word is consensus among us, not depend on even the minister.
Yeah.
Sorry, between us. So the next panelist is Prof. Edi Raharjo. Please, Prof. Edi. And the comment from the speaker after the third, Dr. Chai Chung have a comment, have an present her speak or PPT, and then just comment from the speakers. Please, Prof. Edi.
Yes, thank you, Prof. Rita. Can I have the first slide, please? Would like to show you some points here. Okay, so Prof. Rita, and then Dr. Pravin, Prof. Aryono, Prof. Agus, all colleagues, thank you for your presence and participation in this webinar. Okay, CPR has never been easy. Teaching good CPR is likewise not easy. Second slide, please. Now, COVID makes it even worse. Before COVID came, we teach ABC, then they changed to CAD. We have a lot of people attending our courses and our trainings in the hope and wish that we can help those people having trouble with their hearts. We have refrained from doing breathing steps then, from ABC to CAD. We rely most of the result from chest compression and disease shock only. Next slide. Okay, now you see here, we can change, the change is just the sequence of the letters ABC to CAD. And then we have refrained from breathing. We rely on chest compression and disease shock, and we change the rules, we change the book. And then we make those people doing the new things. Now, we learned that even chest compression exposes considerable risk of transmission. So frankly speaking, how many chances the patient will have with only chest compressions and delay in PPE and things like that? Next slide. We have made the training for thousands of people. This is one, for instance, when we came into a Muslim campus and then we trained 3,000 of them there. So the biggest question is, how can we retrain thousands of people formerly trained in the pre-COVID BLS with an evidence-based new safe BLS in COVID era? We don't know the answer yet, but let's think about that to see whether there is still a place for CPR in the next era. Maybe another slide, please. Okay, so if we all have any idea how to retrain thousands of people formerly trained in pre-COVID BLS, now with the new one, safe BLS in COVID area. Thank you.
That's all,
That's all.
but it is full of meaning. So let me just try to find the solution, how we retrain the pre-COVID BLS, basic life support. So the last panelist is Dr. Kai Chung from National Hospital, Singapore. Please, Dr. Kai Chung.
Good evening. Thanks, Prof. Rihada, as well as Dr. Faisal and committee members for having me. So I enjoyed the talks prior to this, and maybe I'll just make some comments in two areas. The first would be involving that of staff safety. I know there's quite a lot of concern when pre-hospital staff and hospital staff, both nurses and doctors and allied health personnel approach a patient with COVID, which essentially is a disease that spreads via aerosolization, as well as a droplet spread and also contact spread. So really the staff protection is very important to give people confidence to treat the patients well, including using CPR. So I think at least in my institution, if we can, we always put all suspect patients with COVID in a single room and highly suspect patients in rooms that have negative pressure. And just as Dr. Praveen has mentioned, every time we do CPR on such patients, we minimize the number of staff and we only send probably at most 3 people in to deal with the patient in the most expedient manner. So we oftentimes would get the most senior person to insert the endotracheal tube, and we use all the equipment that's available, including video laryngoscopes and bougies, to facilitate intubation. We also take care to prepare and train and simulate all these situations beforehand, because coordination is very hard once you wear the PPE, and with the mask, a lot of times the instructions and the verbal communication is being muffled. So preparation, training, and simulation beforehand cannot be emphasized enough. And also, like Dr. Praveen has mentioned, we really prepare sets of PPE outside patient rooms so that these are easily accessible and it takes minimal time for people to put it on. I mean, the last thing we want is for people to rush in a room without adequate protection, and then they also get affected. And this is really will be a great loss to our healthcare manpower and our staffing. One thing I would also like to add on to the previous presentations is that don't forget about safety in transport, because a lot of times patients can be in different parts of the hospital, not only in the ICU, they can be in the emergency department, they can be in the general ward. And if patients get resuscitated successfully in these areas and gets transported to our ICU or maybe to other areas like the CT scan room for urgent scans, then the route of transfer is very important. We have to assure that not only are the staff involved adequately protected, and this includes the doctors, the nurses, the porters, but also even security personnel that help clear the way from the site of collapse to the ICU. And all these routes between the site of collapse and ICU needs to be pre-planned so that we can actually make sure that we don't contaminate other areas of hospital while transporting patients. And then after that, once transport is done, then all equipment needs to be carefully wiped down in order to reuse all this equipment for future patients. Well, apart from staff safety, the other aspect that is very close to the ground would be really the ethical balancing of decisions to intubate, to do CPR, at the ground level. I know a lot of talk has been done at the high level by Prof. Eddie, by Prof. Ariono, and also Prof. Agus, talking about policy making. But I guess policy making can only guide ground clinicians so much. But when faced by a patient in front of us, what do we do? One very useful framework to analyze our thoughts on the ground without too much input required from elsewhere would be to use a four-topic approach to resolving ethical dilemmas. This was actually described by Professor Johnson from University of Washington, and it's really a practical approach that is not only used by ground clinicians, but also by ethics panels. So you can actually use the same panel decisions on the ground. And what does this four-topic approach involve? It involves actually categorizing the information, the facts and details into four topics or four themes, which Prof. Johnson actually describes as quadrants. So the first quadrant would be something that's very familiar to all of us as medical practitioners, which are the medical indications. I mean, would this patient be survivable? As Prof. Ariono has mentioned, if the sets are very low, like for example, less than 80%, quite obviously not survivable, then obviously we don't do CPR. But you know, if it is more survivable, if the chance and the prognosis is better, then maybe by medical indication, we should do CPR. The second area would be that of patient preferences. And indeed, for such things to be most accurate, the patient himself or herself should have been asked about advanced care planning before. But sometimes that's not possible, and so we have to approach the family members. But I guess we should always remember that patient preferences are not just having an option of whether to do CPR or not. There should also be an option of comfort care or palliative care. So I also believe that appropriate palliative care must be provided to hypoxemic patients, even when the decision is to withhold or withdraw life-sustaining treatments. So for example, the use of morphine, the use of fans to actually blow on the face, all these are quite important to provide comfort. And I guess there are many national or international recommendations as a matter of good clinical practice in this area. The third theme that Professor Johnson has described would be that of quality of life. And this is probably one of the more difficult things to resolve, because quality of life is basically assessed from the patient's viewpoint. And sometimes you will know that even very, very badly disabled people can lead very, very good lives. They can even be motivational speakers. So for this, is probably the most difficult to decide upon. And well, we just have to make our best guess at this together with the patient's family. The final quadrant to identify and also to describe would be that of contact features. So this quadrant really encompasses a whole range of things we need to consider, including social, cultural values, religious values, ethnic values, and also legal considerations. And all these things are really influenced also by national guidelines and international guidelines. So I think on the ground, in summary, we have to consider many things. And one of the most useful frameworks, at least from what I do on a day-to-day basis, is to use the Johnson's four-topic approach.
That's all?
Yeah.
Dr. Saichu? Yeah, thank you very much. So I would like to ask the speakers, Dr. Pravin and Dr. Prof. Agus, to give comment about the three panelists, what they say. A short comment from Dr. Professor Aryo, Prof. Eddie, and Dr. Kai Chung. Please, if there is some comment. Dr. Pravin?
Mute.
Unmute, please. Yeah, okay.
Yeah, I do appreciate the words of wisdom from Prof. Eddie, Prof. Aryan, and I mean, nothing can replace years of experience and then in-depth knowledge about the other conditions. And definitely, I mean, it's a very good, I like the idea of having planning and involving local bodies so to make sure that whatever we are doing is according to the preferences of the patient, but also we have to take into consideration there are multiple angles to this. There are social issues, there are religious issues, there are legal issues. And if we can involve our professional bodies more, and if they are more active, then definitely like we can have some better guidelines. Thanks a lot for that.
Okay, thank you too.
Thank you for three of the other speakers, Prof. Aryono, Prof. Edi, and also Dr. Kaichun. Prof. Aryono give us the what we call the recent medical indications complexity, and Professor Edi give us the reflection about the existing CPR, whether it will be for good or not. And then Dr. Kaichun, I'm agree that you use the clinical ethics theory by Johnson and Ziegler. Yeah, but it's all of the three panelists is based on the the medical indication, whether it is in my knowledge, to my knowledge, because I'm not an intensivist. To my knowledge, that the only efficacy, like a Kramer said, that it's only the cardiac arrhythmia. Yeah, it is a very good prognosis. But the other one is below the 25%, the efficacy of CPR. So it is a little bit, like a futile situation. Yeah, according to the medical education. Maybe I have wrong perception. Yeah. So I think in the complexity will be resolved if we use the robotic. Hopefully that will be a robot, the clever robot can replace us. So because in my consideration, all of the basic assumption should be the COVID. It's not only a one-shot moment; it's a long-term moment, and we should, prepare or maintain our hospital duty, and also with our preparation with the medical doctors' expertise. So we should prepare it in the long-term situation. So that's why that in that situation that while we facing the COVID patient need CPR, a little bit, that from the point of view is, the autonomy of the patient can outweigh and compare with the beneficence principle and also the justice. It means that the price of medical doctors, especially the specialists, is very high. It's very expensive to be maintained for the next patient. Thank you.
Thank you, Prof. Agus. You make me think about the futile treatment. But before we just go to the invited panelists or the participant, I would like to ask Dr. Kiki Lukman, because you are one of the panelists, and after that, Dr. Arif from Jakarta. How do you think about what Prof. Agus just mentioned to us? Because Prof. Agus see it from the other perspective. How do you think, Prof. Agus? Last comment.
Okay.
Dr. Kiki?
Yes. Okay. Thank you very much, Prof. Rita. Thank you, Prof. Agus. For your presentation. Can anybody listen to my talk, my voice?
Yes.
Yeah. Okay. Yes, it is not easy in practice, especially in a big hospital, teaching hospital. So many doctors, many residents, many young doctors, many specialists in Indonesia, we always think to two things. They always ask about the permission or the informed consent. Although we have already the regulation for the Ministry of Health that we can do CPR in three conditions, as long as I remember. First, the unconscious or very life-threatening patient, and then second is patient with pediatric patient who always need guide from their parents, and they always ask about the permission to do some important procedure for life-saving procedures. But I don't think this is a dilemma for us, as long as we have the knowledge, we have the skill, we have a good judgment. So patient safety comes first, I agree. But the problem is, according to my experience, decision to make CPR, I agree with Prof. Aryo that we should have a very clear guideline, which one we have to do resuscitation, which one we don't know. But the problem is sometimes we have a lot of patients at the same time, like in the casualty and disaster situation, car accidents with many people, many casualties. So in the era before the COVID-19, it is easier to manage, to control all the patient and to mobilize all the staff. But in this COVID-19 era, I think we have a lot of problems, especially in a district hospital, not in Jakarta, in a big city. The problem is so many people are not well trained. They don't have enough time to train, to have simulation. And when we face a patient with suspected COVID-19, of course, we have to kind of situation, in the situation that we have a good pre-hospital care, such like Prof. Aryo said, that if we have good communication with pre-hospital team, so we can prepare from the beginning until to maybe to ICU. So we must have a good preparation. We have good triage, good isolation room, a good protocol. And I think we don't have face serious dilemma there. But the problem is, if the patient come directly to hospital with delays, so there are always some delays in action from the medical staff, from nurses, because of limited number of PPE, maybe not good, well organized. So there are always some delays in performing resuscitation. So I believe that at the end of the day, it relies on the experience, the judgment of the most senior experienced physicians or anesthesiologists or surgeons in charge in emergency. So I believe if we always stick to the rule of ethics, as Prof. Agus said, that beneficent, non-maleficent, autonomy, I believe we can arrive into good decision making to save patients' life, and in the same time, we also can save our health and our safety as medical staff. So I think we need some old or experienced people to show as a role model how to apply this ethical concept. But I believe that all doctors already have a good motivation and dedication in Indonesia to save patients' life. But we need a good system. I agree with Prof. Aryo that in order to have a good system, we must sit together from different perspectives, ethical perspective, religious, anesthesiologists, surgeons, to have a good protocol in hospital from the beginning, from triage, emergency room, patient transfer to the ward, to the ICU, and so on. I think that's all I can say, Prof. Rita.
Thank you, Dr. Kiki. But I will back to the Prof. Eddie. Prof. Eddie, Dr. Kiki tell us, just mentioned about not well trained. And I think what you just tell us about the BLS pre-COVID, how about the sukarelawan, volunteers? Do you just give them a special BLS for COVID patient? Because there are so many volunteers nowadays, yeah. And the doctor muda that will work with us in the hospital. How do you manage them?
Unfortunately, we don't reach that point yet, Prof. Rita. So probably we need to make a, what you call that, a rapid response, yeah, to make them change the practice. Yeah. Normal. Yeah.
We have trained 1,000 students, but they are trained with a normal BLS. And how if the sukarelawan or volunteers will be trained? It is quite a question. Yeah. So I will like to ask Dr. Aris from Jakarta. Yesterday you just told me that you have a question, Dr. Aris. Arif from Jakarta.
Thank you, Prof. Rita. Thank you for all the speakers. Yes, you can hear me.
Yes.
Okay, right. Actually, my question has been answered by all the speakers. I agree with Prof. Rio, Dr. Kechang, Dr. Kiki, and Prof. Agus. But maybe I want to express what all the physicians, the intensivists, the doctors who are treating the COVID patient right now, in this present situation where there are no regulation, no consensus, no statement, no recommendation about doing CPR on COVID patient. Is it proper that all patients who are admitting to the ICU or the wards, we can determine in the beginning that this patient, we choose this patient, determine this patient is a DNR patient, or this patient can apply CPR if experience cardiac arrest. So that's what I think all of us is questioning. Are we violating any medical or ethical issues by doing this, where there is not yet any guidelines or consensus?
Yeah, guide. No.
That's
yes.
what my question or commenter. Thank you, Prof. Rita.
Thank you, Dr. Agus. Prof. Agus, maybe you will give comment about this question, this statement. Prof. Agus, about food time. Yes, Prof.
Yeah,
please.
if we can conclude that the situation is very complex, because we should first make a clear of the basic assumption. So in this context, that to my knowledge, that one is that all of the patients in the red zone, of especially, or in the situation of pandemic now, it is with the phenomenon of OTG, people without symptom, it is potential to make a contagious for healthcare professionals. So that's why that all of the patients come, it should be considered as a COVID positive, this one. And the other one is the efficacy. And then the third one is, I will raise this, in this context is, so the future doctor will come to the problem of prognostication. So the prognostication is consists of many of diagnosis and also the efficacy of the treatment, and then we can down to earth to one unique patient. In this context, is like the quality of life and also the contextual features, as Dr. Kai Chung said. Yeah. So it is a very difficult situation because that we do not have the guidelines, but in the context of emergency, every medical doctor can make their own judgment, according to the best practice and the best evidence, and also with the good intention. So it is in the pandemic situation, all of situation of the judgment can be permissible, as long there is no bad intention. Thank you.
So long as there's no bad intention, it is the key words. Dr. April, you will just say something about comment or question. Please, Dr. April.
Okay, thank you, Prof. Rita. Hello. Okay, thank you, Prof. Rita. I think that is still a dilemma for us. The main problem CPR in COVID patient. Number one, a correct CPR is not easy. Correct CPR is not easy. And high risk of transmission for COVID. And number three, as we know that low success rate in COVID patient in cardiac arrest. And for help the patient, we need a rescue team has a minimum of 5 members. I think 4 main problem in CPR for patient COVID. And really, I do not agree if the CPR is done by a robot. I think it's impossible, I think. Yes, because a feeling of helper come into play. We should be compassionate in this situation. No, so I totally not agree if CPR is done by robot. This is my comment. Not easy. Yes, okay.
What just the Prophet told us that you use the mechanical pumping, yes?
Remember that golden time for CPR is just for 5 minutes. And the first, we do chest only CPR and prepare our mechanical compression. To setting the mechanical compression need more than 5 minutes. So the compression by manual is the first thing.
Yeah.
Okay.
Maybe Dr. Pravin, you will give comment. This just Dr. Apple is like I myself. I think we are rather traditional, but using mechanical pump, it is okay. But Dr. Apple mentioned that it is not human or without feeling. How do you think? But
Yes,
it is safe.
Yes, Prof. Regarding Dr. April's comment about setting the mechanical compression device, yes, I mean, it can take some time if you're doing it for the first time, but that's where the role of preparation and mock calls comes. And typically, I mean, we train our providers and our nurses so many times with mechanical compression device so that they are able to do it on mannequins like in less than, I will say, 15 seconds. So that way, like, I mean, I think a very good, I mean, appropriate amount of training is going to significantly decrease the time that we are putting the mechanical compression device. If someone is putting it for the first time, it's going to take a lot of time. But like in our settings, within 10 seconds, I mean, we have set protocols and then we are moving the patients and quickly we slide it. And Yes, regarding your question, Prof, about the feelings, yes, I mean, it is a robot, but at the same time, I agree with Dr. April that it will be very difficult to have the robot do everything. I mean, of course, we can take their help in chest compressions, but again, I mean, there's a physician who is making sure that the machine is working, is doing the job that was required. And I mean, 99% of the times they do, I mean, if it's well positioned, they apply very good chest compressions, but there are some situations where we have to step in and we have to modify the protocol, or we have to modify the way it is positioned. So yes, I mean, machines, they are helpful, but they do need a driver. They do need a physician to make sure that whatever they are doing is appropriate and we are not harming the patient by their use.
And I think, Prof. Rita, because all who play a role in CPR must use level 3, the highest level for the PPA. It's more difficult for, yeah, there's a problem. Yeah.
Using the device, you know, it is a level 3, so it's so big, and the weight is about 10 kilos? Not. So next, I would like to ask Dr. Dr. Bambang Pujo. Do you ever, you are there, Dr. Bambang Pujo? No?
Dr. Airlangga.
Or Dr. Airlangga? Dr. Eri?
Yes.
Yeah. I would like your comment about this is a question actually for the all of us. What are the consideration to declare DNR for a COVID patient? It is a question from anesthesiologist. So when you say do not resuscitate,
it's little bit. Thank you, Prof, for the question. And first of all, I would say to thanks to I mean to our previous speakers for the good lectures and good discussion. And the second one's I would like to answer the Prof Rita question, and from the audience, that's in the pandemic era, it is difficult for us to decide to make do not resuscitation. And but in the clinical setting, in our ICU, in some in the two hospital, in the one is private hospital and another is a government hospitals. The problem is because of, like Dr. Pravan said, that we have a lack of resource. We have a problem with body or nurse to help us to make a resuscitation. We have to struggle with our PPE, because we have to stand with the PPE until for 8 until 10 hours. This is also heavy also for our nurse and our medical doctor staff in the ICU. So, and also we don't have a good barriers when we are doing resuscitation. If we got the patient is cardiac arrest, we found that some little bit strange phenomena, Prof. Maybe in nowadays that some family members or some also in the hospital managements, they ask to anesthesiologists or intensive cares to put the patient to make intubation or to make the airway safe. But if the patient is RS, they don't want to make a chest compression. So they just want to intubation, but doesn't want to chest compression. So it is a little bit strange for me because the CPR is whole packet because A, B, C. That's all. But we already explained to the family and they explained to the hospital management that uh, intubations include the all for this resuscitation packets. So not just intubation or not just chest compression. So that is my 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 answer, Prof.
That is our problem, Dr. Eri. I know that and understand. And I would like to ask Dr. Kai Chung, how you do it in Singapore? Is I think it is no no trouble at all because everything is okay there. But do you have any problem in intubation or resuscitation in if you have COVID patient? CPR, I mean.
Yes, I think in Singapore, we still face the same problems as everybody else, whereby there is at least initially a lot of fear over staff infection. And therefore, we place a lot of emphasis on training and retraining. And in particular, we refitted everybody for the N95 mask because our N95 mask fitting was done very long ago, maybe 5-10 years ago when people joined the hospital. And we realized that after a while, either people lost weight or they put on weight and the mask doesn't fit anymore. And therefore, this is really one of the first things that we did. After that, there was this rather difficult situation of determining what is enough protection, because we all say PPE, but what is PPE? So WHO at the start, if you recall, had a fairly complex matrix of PPE. Is it surgical mask? Is it N95? And I think we have evolved to establishing PPE as at least 4 components: the N95 mask, the goggles, then with the long sleeve gowns, as well as the gloves. So everything else is actually optional. So whether people wear boots or not, whether people wear a cap, they're all optional. And we find that at least for us, those 4 components, gown, gloves, goggles, as well as N95 mask, has protected healthcare staff, and we haven't fortunately gotten any infection. I would also like to maybe talk a little bit on one of the points raised, whereby even after a lot of ethical balancing, on the ground, we have difficulty. And I completely agree, because we have many people with rather vague conditions, and also with prognosis, as many of speakers have mentioned, that it's not that clear. I mean, we are not computational robots, right? We cannot say that, oh, there's a 30% chance of survival, there's a 25% chance of survival. Everybody is different. And for us, if there is uncertainty, sometimes we err on the side of giving the patient the benefit of the doubt. And we use something called the time-limited trial. So whereby we actually do the CPR, we place a patient on a mechanical ventilator for maybe anywhere between 24 to 72 hours. And we give very specific goals and discuss it with family. For example, we say, okay, if the vasopressor requirements come down, we should continue. But if they escalate and now the patient's on 2 vasopressors, for example, vasopressin as well as noradrenaline, then maybe it's time to withdraw. So family members have a fairly good idea of what are our intermediate targets in order to either extend the time-limited trial or to withdraw care when things are really futile. So I mean, we still face the same problems as everyone else, but I do appreciate the comments and learning from everyone.
Yeah. Okay. Thank you, Dr. Kai Chung. I think I will ask you 1 minute for the photo making. We can just continue the discussion, but please open the window because we have to make a photo. Yes, Dr. Ike, Dr. Eri, and Dr. Herdiani, and everybody just open the windows. And Prof. Edi is very super. Yes, okay there. But you have to look at the mirroring, Prof. Yes, okay. Because, yeah, okay. So just 1 minute,
Yes.
just hitung.
Yes.
1, 2, 3, and then stop.
Professor, doctors, I'm going to take a photo in the count of 1, 2, and 3. Okay, then again.
It's okay?
Yes,
Okay.
yes it was. Say
Thank
cheese,
you
everyone.
for
1,
all.
2, and
It is a remembrance for us that we already we meet in Surabaya. So thank you, Prof. Edi, if you have to leave now. And then I just one question from or maybe from the panelists invited, Dr. Ike, Dr. Tini, or I forget the names. Or if there's question for the panelists or the speakers, Dr. Ike, Dr. Prananda is already say something. Dr. Arif and
maybe I have one question, Prof. Rita.
Please, Dr. Ike.
Yes.
Dr. Ike is from Bandung,
From
Unpad,
Bandung.
University of Pajajaran. Yes, okay.
This is about maybe this is an ethic questions, maybe for Prof. Agus. One of your slides said that doctor safety is more important than patient safety, especially in this situation. And maybe we know that in nowadays we are the number of doctors in Indonesia is very limited. Even general practitioner, like Prof. Aryono said before, that in some places in Indonesia there is only one doctor to take care of 200 COVID patients. So in this situation, maybe it's true that doctor's safety is more important than patient safety. I need some comment from, especially from Prof. Agus. Thank you.
Please, Prof. Agus.
For the question, that's a very good question. Yeah, during the time that Professor Rita already asked me to make some presentation, I always read, and then I can conclude for the conclusion because doctor safety is more important in compared with patient safety. One is due to the we do not have the what they call the robust evidence for the efficacy of the CPR. This one. The one is CPR is not the standalone procedure. It should be connected or related with the availability of ICUs, ventilator, and something like that. Okay, so it means that I just also learned from other panelists here that it consists of five healthcare personnel, at least for one patient. It is intensively resource based, The third one is we have the assumption that due to the we do not up till now understand about the pathogenesis of COVID diseases, we make an assumption that it will be last for long term. So that's why that this is a lot of the search capacity and also the availability of our medical doctors as scarce resources, you know. So in this context, the ethical consideration, we should, balance, yeah, like Professor Aryan already said that we are an oath-taking profession, but that we are, ya mempertaruhkan diri, only one patient, while we are understand that it is a highly potential.
Yes.
Yes, yes. Have the measurement. Yeah, I think it can be, can be a proper judgment.
Okay.
Thank you.
Dr. Ika, you are satisfied?
Yes, thank you, Prof. Agus. Yes.
I think I would like to ask your comment. If the doctor is in danger, it is logic that he will just prevent for himself, because the doctor is too value for many patients other than the patient in his hand, because otherwise he will dead because of COVID, and there's so many patients that rely on him. How do you think? First the patient or first the doctors? If the doctor is in danger, I mean, no the preventive device, and the doctor is have a vulnerable include in the vulnerable cluster. How do you think? Because I think I fully understand what Prof. Agus said. How do you think, Dr. Pravin?
So that's a very good question. And one of the things that we need to keep in mind is that as physicians, as doctors, we are taking care of patients every day. It's COVID patients, but also that doesn't, we do take care of non-COVID patients too. So it's a very difficult situation, but we need, when we are, for example, when a patient has got cardiac arrest and when we are not rushing into the room without wearing personal protective equipment, we are not only thinking about ourselves, but we are thinking about hundreds of patients which we will be taking care of over the next 3-4 weeks, or maybe thousands over the next month. So if we don't protect ourselves, we are not only putting ourselves in danger, but the future 1,000 patients, I mean, there will be one less physician. So it's very important for us to take precautions, because we are, by protecting ourselves, we are protecting other future patients. And again, cardiac arrest, it's at one end of the spectrum, but there are many patients where our expertise will help in going to that situation, and we can prevent cardiac arrest from happening. So when we are, it's not that we are closing our eyes towards patients, but we are thinking about patients. That's why we want to take full precautions and have a personal protective equipment before rushing into the room.
So, Prof. Arya, we have to make a consensus about this one, so everybody feel happy and not feeling guilty if we just decide to don't do we cannot do the resuscitation. The last question, we have still 3 minutes, is for, I think, Dr. Faisal. If you are there, please give comment about this last issues. Dr. Faisal from Makassar, because you are in the list of invited panelists. Anda? No. And how about Dr. Pujo? Because Dr. Pujo is here. Dr. Pujo is a young doctor with full of expertise about a COVID patient. Dr. Pujo? Yeah. The question is, Dr. Pujo, it is the last question for the session because it's all about 5 minutes to 9 Indonesian time, Surabaya time. Hmm? Dr. Pujo? Pasien, yeah. So,
Prof, can I comment?
Okay, Dr. Arif, please.
Sorry, at the last moment. There's one statement that I've heard that in this pandemic situation, in handling a COVID patient, there is no emergency. So, there's no such thing as rushing into an emergency situation COVID patient. You should take time to protect yourself. That's just my comment, like Dr. Pravin just mentioned. Thank you.
So you mean that if we are not prepared yet, we do nothing at the time. It is okay. In simple words.
Yes.
Yes.
Protect ourselves, but
Is there any comment? Yeah, I know. And how about Dr. Kiki? I think you are pro patient first. Dr. Kiki? Di unmute, unmute.
Okay. But what I want to emphasize that we have to prepare ourselves from the beginning. When we are in charge in emergency room, I think in Indonesia it is better we always use adequate PPE, because we cannot clearly differentiate between COVID patient or not, especially in the surgical emergency room, especially for accidents, patients suffering from accidents, mass casualty. It is difficult. So it is better we are always prepared. When we are entering an emergency room, we use PPE, adequate PPE according to the hospital guideline. So we are always prepared. But it is not easy in the setting of teaching hospital. So many people around coming in and going out, and it is difficult to organize and coordinate. But the basic principle, I agree, when you are working in emergency room, so you are always wearing your PPE, adequate PPE. So like Prof. Agus said, that we always consider every patient as a COVID-19 patient, unless we have a good screening of the patient. And the other thing is how we design the emergency room. Like Prof. Aryo said, if we have to divide it room, isolated emergency room for COVID patient and the other room for the different patient, so it is easier to manage. So basically, I agree. As long as we always prepare with ourselves. But the problem is, about discipline, about the availability of the PPE.
Okay, thank you. So before we close, still 2 minutes. If there's any question or comment, please. As I think everybody is satisfied with this discussion. And I think it is difficult to make a summary, but at least there are so many things that influence when the decision to do or not to do the CPR in the COVID patient. Which one? Patient first or doctor first? It depends on the condition. But I agree with Prof. Aryo that we have to make a consensus. At least we have a guidance when in pandemic state, not only the COVID, but the other infectious disease, we have to decide what are we plan to do. Because it's not easy, like Dr. Apri mentioned that when you are in that situation, what will you do without, you are not prepared. For instance, in the jalan raya, highway, you are not bring your every device for prevention. And you know that the patient, you don't know, but you have to do the CPR. So many questions, yes. So thank you very much for this discussion, and I hope we will meet again with new issues. And maybe at the time we already have a consensus between the professional, Prof. Aryo, independent for what the government said. I will thank you very much, and I will give back to the host. Please, Dr. Dian.
Thank you, Prof. Okay, for closing, I would like to thank all the speakers, panelists, guests of honors, and colleagues who attended this webinar, as we could discuss and had more knowledge and information about CPR in COVID-19 patients. Also, I would like to thank you to our Airlangga Webinar Conference Series Committee, who had set up this wonderful webinar. As a host, I apologize for any shortcoming in the implementation. So see you again in the next AWCS session. Stay safe, stay healthy. Good night all. Wassalamualaikum warahmatullahi wabarakatuh.
One thing, maybe Dr. Imran will show you the next webinar tomorrow. It is about the COVID hospital. It is something that new in Indonesia, the specialized COVID hospital, how the professionals think about that. Like in the Jakarta, Persahabatan, Prof. Aryo, we have a special COVID hospital in Jakarta, Rumah Sakit Persahabatan, but not yet in Surabaya. So thank you very much, and we hope you will attend this conference tomorrow. Ya, show it.
Thank you.
Terima kasih.
Thanks a lot.
Thank you.
Thanks for having me.
Thank you.
Thank you, Dr. Pravin.
Thanks a lot, Dr.
Aryo.
Pravin, Dr. Kajung, and everybody there.
Yeah.
Hope we meet again.
Terima kasih Prof. Aryo.
Thank you
Prof.
very
Aryo
much.
and
Dr.
everybody there.
Arif,
Prof. Agus.
Prof. Agus.
Dr. Pravin. Thank you.
Okay.
Yeah.
Bye.
Bye.
Thank you.
Bye.
Stay safe, folks.